from two articles only. I will share the articles. The first article will be the Cervical Cancer Screening Guideline 2023. Hopefully you have the guideline. Okay. The other article will be the update of cervical cancer from the ICGS 2025, the article. Okay. So basically it's actually cervical cancer. Okay, the topic is very, very large. Screening, staging, and evidence-based management. I do not think I can finish within half an hour. Even though just the cervical cancer, I cannot finish within 1 hour. If I will just rush through the salient point that you need to know to cater for the exam purpose. Okay, not for any other things. As you know, cervical cancer commonly occur in the low and middle income countries. Okay, 2020 approximately about 600 new cases with about 350 mortalities. 85 to 90% occur in low and middle resources regions. As we know, the main culprit is actually persistent infection by HPV. Okay, high risk 16-18, main culprit 71% of the cases. In fact, actually, the whole HPV occur about 90% of this cervical cancer. Later on, you will see the slide. What are the HPE diagnosis of cervical cancer? We subdivided it into HPV associated and HPV independent. Okay, 16-18 main culprit. Okay, followed by 31, 33, 45, 52, 58. Although 52 and 58 are commonest among Malaysian women, but still 16-18 is still the main reason. This picture shows you the pathogenesis of the cervical cancer. Once a woman caught with HPV infection, she will not progress into cervical cancer. It's the persistent infection followed by the low immunity, and of course with the other genetic factors. Okay, screenshot this. Okay, how do we prevent cervical cancer? Cervical cancer is the only cancer that we can prevent by primary prevention, by HPV vaccination, followed by secondary prevention, screening method. So as you can see here, by primary prevention is actually by giving HPV vaccination. That's actually in our national program. Oops. Nevertheless, we have a very fantastic secondary prevention here. Starting from 1967 or 1967, we have the national screening program by pap smear, followed by liquid-based cytology, and the latest is actually by HPV, primary screening by HPV DNA test. So we can catch our woman before this woman progress into cervical cancer. Okay. So as we know, WHO strategy by 2030, the WHO aim to eradicate cervical cancer. Meaning here is not actually totally 0%. ASR we aim to reduce below 4. Age-specific rate below 4. So that's what we call eradicate the cervical cancer. By how? There are three strategies. 90% of the girls fully vaccinated by HPV vaccination, which we almost achieved that before the pandemic. But after the pandemic, we are hanging around 80 to 88% of the vaccination rate. 70% of the women should be screened by the age of 35 and again by the age of 45. This is actually the aim. And 90% of those women diagnosed with pre-cancer, meaning the low SEAL and high SEAL, should be properly treated. We achieved the strategy 1 and strategy 2. But strategy 1 and strategy 3. Strategy 2 a little bit difficult for us as our pick-up rate for pap smear hanging around 40 to 60% only. Okay, this another slide shows you the similar things. Okay, treatment-wise by FIGO, okay, primary, secondary, and prevention and so treatment. Okay, so I go to the primary prevention first. As we know, HPV vaccination first scheduled in 2006 Malaysia, started by 2010. Okay, the national HPV program. So we have bivalent, quadrivalent, and now it's actually the G9. Blah blah blah. So what are the benefits? Okay, you can see here. The HPV vaccination managed to reduce the prevalence of HPV 16-18 by proven. This is actually a very, very solid data. Okay, reduces the prevalence of HPV 31, 33, 35. Also reduces the anal genital warts and CIN2. CIN2 now is actually low SEAL. CIN1 and CIN2 are old terminology. Okay, You can see here HPV vaccination actually does the wonder by reducing the precancerous of cervical cancer, and thus it really reduces the incidence of HPV the cervical cancer. And the best thing is actually it reduces the incidence rate ratio of cervical cancer by 0.12. Okay, you can see here. So what are the secondary prevention? Okay, secondary prevention by national guideline now by 2023, actually we already started aim by 2019, but the guideline came out by 2023 only, is by HPV, primary HPV DNA test. But we nevertheless we have other methods. The aim is actually to detect cervical precancerous lesions such as low seal, high seal, or sometimes adenocarcinoma in situ. And it's not just to diagnose, but also to treat the respective abnormalities. So there are various screening methods, started from VIA, visual inspection with the acetyl white, which still practicing in regions such as Indonesia, remote area of China, we still practice that. But it's not the recommendation of WHO anymore. Pap smear or cervical smear, now we move to the liquid-based cytology, LBC. And the latest is actually by the HPV DNA test. Okay, once we detected the abnormality, we should provide treatment to the abnormal cells by doing either colposcopy or lip or less. Okay, it depends just the name. Okay, how about the current cervical cancer screening? As I mentioned, you can see the guideline here 2023 is actually the MOH of the aim is actually offer HPV DNA based testing as a primary screening. Okay, how do we do that? Recommendation is actually, you can see here 30 to 65 years old. So by doing HPV DNA test, if normal, if no high risk detected, can screen every 5 years. Okay, the question now is how about those falling outside this age group? Where in my UK is 25, but WHO and Malaysia is actually 30. How about those less than 30 years old? We can still offer them cytology tests, either pap smear, conventional pap smear, or liquid-based cytology. So now the national guidelines say you do first 2 every year. If normal, negative, for malignant cell, you can do it after that every 3 years. Okay, this is actually by cytologies. And for those more than 65 years old, who had never screened before either by HPV DNA or cytology, offer them HPV test. Clear? You can see from this guideline, this book. Actually, few pages only. I just summarize it into the diagram. Okay, so aim is actually 30 to 65 years old. Anyone know why below 30 years old we do not offer HPV test? Anyone know? Reasons are, these are the age that actually they are the highest incidence of HPV infection. It comes and goes. So in the normal healthy woman, bodies can fight the infection. So it comes and goes, there's no point, and it's actually not cost effective if we screen those women below 30 years old. So the best is actually 30 to 65 years old, every 5 years, if negative or high risk. Clear? And what happened after that? The whole guideline, the most important is actually this, I can't remember which figure, you just read the guideline, later on I'll just forward to one of you. Okay? You just know that the Malaysian guidelines subdivided the management into, even though as a primary screening, we subdivided into high risk, 16-18, non-16-18. So you can see here, 16-18, we can do triage of cytology again, or we can straight away refer for colposcopy. This is actually high risk 16-18. For non-16-18, we can always triage with another cytology test. Make sure we still do what we call co-test, still triage with the cytology. If cytology turns back to be ascus, low seals, or high seals, go for colposcopy. Okay, the rest, blah 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 blah. Okay, either liquid lah, this lah, that lah, or that. On the stem cell, actually everything in the guideline. Clear? Okay. The guideline will cause a little bit confusion because it's still we still put in the abnormal cytology flowchart as you flip through the guideline behind that. But remember, we are going for the primary screening by HPV DNA, HPV test. So whichever thing is HPV DNA or HPV test is actually primary, followed by triage by cytology. The cytology part, the flowchart for abnormal cytology, you can refer to the subsequent figures in the guideline there. For those who have, actually the guideline you can download from any NIH website. Okay? A little bit confused later on if you read through the guideline. Okay, how do we do the screening? They have a lot of methods. The proper one should be by the doctors, the HPV smear. Okay, we can ask patients to have the cells sampling, and nowadays we have some data has shown that urine test actually reveals a quite high sensitivity of these HPV tests. Okay, Thailand, China, they have a lot of data, but not in Malaysia. Okay, we are yet to publish the data yet. Okay, now we go to the staging of the cervical cancer. Screening, I foresee not much issue, but to discuss in further, this actually will take another 1 hour. It's actually a very, very lengthy discussion, especially if you have the abnormal smear, low seal, what to do, high seal, what to do, ascus, what to do, depending on the age of each patient, each individual, different management. Okay, baca dengan okay, OB akan tanya, don't worry. But we also sometimes be confused. Okay, now we go to the cervical cancer. Okay, by staging wise, the treatment for cervical cancer is actually we need to know by staging, and also by the staging we will categorize the treatment according to the different stage and age of the patients. Okay, because staging blah blah blah. As we know, we have the latest staging 2018. Okay, tak payahlah baca. Okay, blah blah blah. Actually, I have a lot of slides here, stage 1 to stage 4, but I do not need to go through that. But what are the key amendments, okay, of the 2018 fecal stage is horizontal dimension of the microinvasion lesions is no longer considered. Okay, usually the last 22009 classification we still consider horizontal dimension, but not in the latest. The tumor size has been stratified further into 3 groups. Okay, this one a little confusing. 1B1. 1B2 and 1B3. 1B1 less than 2 cm, 1B2 2 to 4 cm, 1B3 more than 4 cm. 1B3 is actually the tricky part. As we understand, traditionally we say 2A up to 2A we can offer surgery, because the treatment for cervical cancer is we try to avoid dual modalities. Either we go for surgery, which will be the radical hysterectomy plus BSO, plus or minus BSO, or we go for CCRT. This is actually up to 2A, means 2B and below. But after the 2018 classification, look at the 1B3. 1B3 is actually the tumor more than 4 cm. The tumor more than 4 cm, actually, we offer CCRT. So the 1B3 is actually another outlier, alien, second alien. Because 1B3 is alien, 1B3 is below 2A. Okay, remember that, huh? And lymph node positivity, which correlate with the broader oncology outcome, assigns to the cases stage 3C. So 3C1 pelvic lymph nodes, 3C2 will be the para-aortic lymph nodes. The latest classification by CT scan or by HPV, we can put down the stage before the surgery. As you know, it's actually clinical, surgical, pathological staging of any gynecological cancer. But cervical cancer, we are allowed to put in whether the lymph nodes involved or not by either R, the abbreviation of R means radiologically, or HPV. HPE is already histopathological examination. Okay. The fourth one will be stage 3C, is actually considered micrometastasis. Okay. Stage 1, tak ada beza banyak. Okay. This is actually, I show you the stage 2, the differences. We sub-classify into the 1B, the 1B3, the stage 1. Okay, stage 2 no difference, stage 3 sama lebih kurang we just put down this 3C1 and C2. 1 will be the pelvic lymph nodes, 3C2 will be the para-aortic, because it carries different it carries significance in terms of the patient progression-free survival and also the overall survival rate, OS and PFS. Stage 4 tak ada beza. Okay, what are the recommendation? Cakap sudah, tak payahlah. I mentioned that before. I mentioned that ni. Settle. Okay, what are the implications? Okay, you can see here The blue color is actually the figure 20. This is actually a study conducted by Masade. Okay, we look at what are the differences. Okay, you can see here the upstage migration in 54.1%. Okay, upstage about 49.8%. Downstage only 4.9% for the early stage of cervical cancer, stage 1 and stage 2. Okay. So what does it mean? So there are upstaging women who are downstage to figure 1A still did not have any nodes metastasis, and whether the attention is actually to the depth of the invasion rather than the horizontal dimension, as I mentioned before. So it actually correlates with the recommendation. And the nodes metastasis which are initially identified by the imaging should be histologically verified. These are the recommendations by this study. So there are actually many studies conducted after the new classification. It shows that the latest classification actually shows more relevant staging as compared to the treatment provided. Okay, clear? How about the histology? Okay, as we know, we are moving towards the molecular classification. So now we know that this is actually the immune checkpoint. PD-L1, program depth ligand 1. PD actually is program depth cells. These are the cells in the body that can program the apoptosis of the malignant cell. We have PD-1 and also the ligands. Ligand will be L1 and L2. Okay, these are the tests that proven to be significant in cervical cancer, as we have the treatment for ICI, immuno checkpoint inhibitors, the anti-PD-L1. Pembrolizumab. So what are the indication will be the SCC, especially 75 to 85% of this cervical cancer are SCC, and frequently this type of cancer SCC expresses the PD-L1 molecule in the surface of the cells. So the implication will be, if let's say this woman with SCC shows PD-L1, they are eligible for ICI, immune checkpoint inhibitor, pembrolizumab, which shows actually significantly improve the recurrence and also the overall survival rate, if we can provide this. But these are very, very expensive novel therapies. Okay, adenocarcinoma less likely expresses the PD-L1. Okay, but may need, we can still give the treatment if let's say shows a PD-L1 may be beneficial. The rest tak ada apa-apa, especially the HPV independent. Okay, this is actually a very important slide. As you read through the HPE of the cervical cancer, nowadays always pathologists will write down that HPV associated or HPV independent. What are the implication? Very, very important will be HPV independence. We need to provide further or adjuvant therapy, and this woman responded lesser as compared to HPV associated to the conventional treatment. Surgery, either surgery or the CCRT. Okay, as we know, HPV associated driven by the HPV oncogene E6, E7, blah blah blah, all that. Okay, very frequently you see the pathologist will write down that I see P16, P53, or that this is actually implicated there. Okay, not already important in your theory, but in terms of your clinical practices, actually it carries a lot of significant things. Okay, one thing is independent poor prognosis, associated better prognosis. Itu saja. Okay, clear? Cause you more confusion, although CBA classification. This is actually a risk stratification for lymph nodes metastasis. Okay, we subdivided into pattern A, B, C. Well to know, but not compulsory to know. As we know, we always look at the LVSI, lymphovascular space invasion, to cater whether we want to subject this patient for further treatment or not. So this classification actually risk stratified the lymph nodes metastasis into 3 patterns. You can see here the red color means actually the risk of lymph node metastasis is 25 to 30%, and always involve the LVSI. So this type of patients actually beneficial. If we can do the PD-L1, we can offer immuno checkpoint inhibitors. Actually, very beneficial from this type of adjuvant treatment. Okay, clear? If you want to do any oncology, yes lah, you know. Your aim is actually pass the exam first. Okay. The key point from here, the staging is actually you need to know what are the key amendments. The stage will be the stage 1, A, B, C. There. Okay. How do we diagnose cervical cancer? Okay, microinvasive surgery will be stage 1A, 1A2, sorry. Okay, will be the microscopic examination. Okay, the report should clearly stated that margin should be reported negative for the disease. For us to say that these are microinvasive disease. So if the margins are positive, 1B1. Okay, these are the HPE reports. Okay, blah blah blah, lesion. Okay, once we see the lesions, biopsy that lesions, do not need to do HPV DNA lah, pap smear lah, cytology lah, anything. Biopsy the lesions, send for HPE. Okay, HPE confirm cervical cancer, do the necessary classification and staging, and provide the respective treatment. Okay. How about imaging? Ultrasound still the best. In a good hand, it can diagnose most of the cervical cancer. However, in a resources permitted center, if your center can provide early MRI scan, MRI is still the best method. Okay, to detect the lesion less than 10 mm, 1 centimeter. MRI is actually the best. Okay, but a lot of centers in Malaysia, we have difficulty to get the MRI appointment. So ultrasound still the primary method to detect cervical cancer. But how about lymph nodes? MRI is still the best. Okay, or sometimes you can go for a CT scan. It depends on the imaging quality. It depends on your CT scan, whether this is a fixed slide or a thin slide. Okay, and also the expertise of the radiologists. Okay. Those days we have the PLNS, pre-treatment para-aortic lymph node surgical staging. Okay, 80% of the patient with stage 1B to 4A cervical cancer or CC have para-aortic lymph nodes met. So this method pumps, major complication very minimal, 9% only, and the lymphocyte formation is actually the most commonest complication. Recommendation is still feasible with low complication. Okay. But with the advances of MRI, imaging, and the PET scan, we seldom do this method anymore. Okay, just for you to know. So now masuk museum lah this method. History really. Okay, clear. Diagnosis. Sempat good, half an hour finish. How about treatment? Treatment wise, before the advances of fertility prevention or fertility sparing surgery, okay, we chop all women. Potong saja. Either we subject all women for surgery or CCRT. Okay, important decide ni. Microinvasion surgery, microinvasion CC, cervical cancer 1A1, 1A2. We can provide the most important will be the fertility sparing surgery, or just a simple hysterectomy plus pelvic lymph node dissection, either by laparoscopically or open. Or in those who had no issues about the fertility issues, can offer radical hysterectomy, very seldom. What microinvasion we go for laparoscopy, we go for fertility and also the simple hysterectomy. Okay, clear. Whereas 1B1, 1B2 go for radical hysterectomy, 1B3 of course radical hysterectomy, blah blah blah, all that. You can see here 1A, 2A. I didn't put out there now 1B3, by right should be CCRT. The latest recommendation. I still put out the radical hysterectomy because we still practice radical hysterectomy for those stage 1B3. Okay. This one you baca sendiri lah. We like to ask lah, what do you mean by extrafacial? What do you mean by simple hysterectomy, extrafacial, and radical hysterectomy over times? Okay, our over times they actually modify radical hysterectomy. You have two classification, pivot and quilio. Okay. Baca sendiri lah. I take out the slide of the image, but you can read out there what do we understand by all these things. Yeah. Okay, 1A1 as I mentioned just now, fertility sparing for those who desire to conceive further. Can always go for cone biopsy first. If margin clear, that's it. then subsequently follow up patients, provided no LVSI. Okay, and margin are clear. Okay, if LVSI or margin involved, we need to proceed with the hysterectomy plus lymph node dissection. Okay, 1A2, fertility desire is still the same, blah 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 blah, all that, but we can always offer trachelectomy. If you offer trachelectomy, always supplement with laparoscopic pelvic lymph node dissection. Very important. The laparoscopic pelvic lymph node dissection, you can either do the sentinel lymph nodes just to see whether the first lymph node is actually positive, or if when we perform sentinel lymph nodes turns out to be all negative, no showing up from the green light, we supposed to follow the protocol, go for the lymph nodes dissection clearance. Okay, clear. There's actually trachelectomy plus lymph nodes for those who desire for future fertility. Okay, 1B1, same thing. Berarti kita tak payahlah, sama aja lah. Just read through the slide. Okay, another important slide will be this. Follow the flow. Okay. Remember, try to reduce or try to avoid dual modalities, means radical hysterectomy plus CCRT to patients, if possible, because it increases the morbidity and mortality to patients. Sometimes because with the advances of imaging and also the IHC, the immunohistochemistry staining, we can avoid this, but sometimes very difficult. We do still provide neoadjuvant chemotherapy, which I will discuss later. Okay, Indonesia still give a lot of neoadjuvant chemotherapy to stringe down the tumor before we bring in patient for surgery. After surgery, margin not clear, CCRT, take some patient. Okay, the aim of early stage cervical cancer, why I stress more about early stage, is actually these are these stage 1 and stage 2. These are the cancer that we can actually cure. Surgical approach, conservative surgical criteria, and so the sentinel lymph nodes. Okay, surgical approach, we have two modalities. One is MIS, minimal invasive surgery, and the other one will be the conventional laparotomy. Before 2018, actually cervical cancer, a lot of things occurred in 2018. Before 2018, laparoscopic actually carries the weightage. It is recommended that laparoscopic versus laparoscopic or MIS carries the same outcome as compared to laparotomy. But after the LAC trial, laparoscopic approach to cervical cancer trial, it shows that actually increases the risk of recurrence, reduces the progression-free survival. Okay, why does these are the systemic reviews from after the LAC trial? 71% higher risk of recurrence in MIS, 56% higher death or mortality in MIS. So what are the theories that we provide? Because before 2018, a lot of people doing laparoscopic. Nowadays we still perform laparoscopic, but during the research. Okay. What the potential theory is actually the impact of CO2 pneumoperitoneum. That's the first thing. The second thing is actually lack of use of peritoneal protection. Okay. The main culprit we identify is actually the use of the uterine manipulator. We put in the uterine manipulator to manipulate the uterus, and it actually plus the CO2. We postulate it causes the micrometastasis during the surgery. So because of all these things, blah 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 blah. Okay, we have the RACC, the Swedish multi-center prospective studies still ongoing to assess the MIS. These studies carried on now or launch is actually a serial launch 1, 2, 3, a serious trial conducted in China mainly to see the MIS without a uterine manipulator versus the laparotomy to see the outcome. Okay, bear in mind, China still practice a lot of laparoscopic for cervical cancer. Actually, these are the main surgical approach for their practice now. Okay, they modified a little bit. They didn't use the uterine manipulator. Still CO2, but they inflate lesser. Okay, They clamp the cervix, do the proper urinary tunneling, push down the bladder, identify the identify the uterine arteries, ligate as near as to the internal iliac, okay, ligate the vaginal branches of the vessels, and they push down, they clamp the vagina first before they remove the cervix. So that actually reduces the risk of micrometastasis. These are their argument. Okay, we still do not know the outcome yet. Maybe by next year or 2028. Okay, clear. So how about this actually, the previous slide, this is actually the argument whether MIS versus laparotomy. For your knowledge, for your exam purposes, MIS still under investigate. Okay, after the leg trial, recommendation by Europe. Ini tak boleh lah. Yeah. By European countries still go for laparotomy unless we are going for the research purposes. Okay. How about the simple hysterectomy versus radical hysterectomy? Systematic review 2021 studies. Okay. Recurrent rate of simple hysterectomy for early stage cervical cancer. I'm talking about all these are early stage. Similar as radical hysterectomy. Yes, we can perform simple hysterectomy. Okay? Blah, 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 concave lah, all these things. Okay, how about the sentinel lymph nodes? Okay? Carries less mobility as compared to systematic pelvic lymph nodes dissection. There's the reason nowadays we go for sentinel lymph nodes. Blah, blah, blah. You have Centix. Blah, blah. What's it? Nanti sentinel lymph nodes biopsy. Blah, blah. Bilateral. Okay. One thing good is SLN, the sentinel lymph nodes, SG is short form SLN, does not increase the node-specific recurrence as compared to the pelvic lymph adenectomy, the systematic. Okay, this is actually very, very important. Okay, these are the protocol. Screen through the indocyanide green, any suspicious, remove. Fail the mapping, the hemipelvis, site-specific lymph adenectomy should be performed, especially if you perform the cervical the fertility sparing for surgery for cervical cancer. Okay. Alah, macam ni lah, the same thing. Important slide lah this one. Okay. How about radiotherapy in early stage? Okay. Useful if patient has no contraindication. Has contraindication for surgery. You cannot operate the patients. Okay. Usually we shine the patient if you are refer to oncology, and either shine by external followed by the internal. Okay. Can do. Well, which are the best? Surgical versus radiology. Radiotherapy. Still option we should offer to patients. Definitive radiotherapy or CCRT is preferred if patient you cannot subject patient for surgery and to avoid the compounding treatment-related morbidity, as I mentioned. You have difficulty to clear the disease, thus prefer for CCRT in early stage of the cancer sometimes, especially those with a very, very high risk, hypertension, diabetes, heart failure, which you have higher risk of on-table mortality. Okay, this is the leg trial, blah blah blah, all that. After this thing, 1B3 and 2A2 CCRT go standard. Okay, remember 1B3 penting sikit sama lah CCRT, sama. Empat. How about the neoadjuvant chemotherapy, NACT? Okay, as I mentioned before, we still can provide the neoadjuvant chemotherapy to reduce the tumor bulk, followed by the surgery. I still practice, sometimes we still practice that. Okay? As I mentioned, the data shows that NACT significantly reduces the tumor size, stroma invasion, LVSI, and so the lymph nodes metastasis. Okay, blah 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 blah. Okay. Some country provide neoadjuvant chemo plus radiotherapy to further reduce the size. Okay, before going for surgery. Not the standard recommendation by worldwide, but we can offer. especially in resources limited, or the waiting time for surgery is actually very, very long. Okay, blah, blah, blah. Okay, ini tak payah lah, as I mentioned before. How about the immunotherapy? Can provide the anti-PD-1, pembrolizumab, or anti-PD-L1, pembrolizumab, 2 dose. It proven, especially in those MSI or DMR recurrence cervical cancer. Follow up, all stages, follow up with a 3-monthly for at least minimally 2 to 3 years, and subsequently 6 months for the next 3 years. Okay, I think I don't think slide lagi. How about the recurrent diseases? Most recurrence are seen within the first 3 years. Okay, you can offer them PET-CT to assess the distant metastasis. Local recurrence always we can pick up by doing the initial screening by physical examination, speculum, and also the liquid-based cytology. Okay, very seldom, very often is actually local recurrence first before the distant metastasis. But I do see distant metastasis. Okay, this one I have only. This one is actually the flowchart for recurrence management. Ya, 30 minit. Kita baca sendiri lah, this one. Okay, thank you. Okay, the important things actually you need to know for cervical cancer screening is actually how to screen, and subsequently the flowchart that I show. Okay, cervical cancer you need to know the staging, the treatment according to the different stage. That's all the key point. Thank you.
Thank you to Prof. Shukartek for that comprehensive and insightful presentation. We will now move on to our next session. To deliver this lecture, may I invite Professor Nimala Kampan, Consultant Gynae Oncologist from Hospital Pantai KL, our former senior lecturer in UKM, to the stage.
Good morning, everybody. Sorry, I lost my voice a bit. I was having flu for the last 1 week, but we will try to. I'll try to present as much as I can. All right, on the topic of ovarian tumor. We are not going to touch a lot on management. I think most of y'all are wondering what this topic is about. Is actually trying to classify your ovarian mass. Okay, so let's try to make this a bit exam orientated. Okay, so you can actually broadly classify your ovarian tumor into 3 categories. One is benign, one is borderline, one is malignant. All right. Now, why we need to know this? Because this determines the principle of management for the patient. Particularly if you can actually give an option of fertility sparing, all right? It also will be good to know the staging of that tumor, all right? So if it's a benign, you know this is usually a non-recurrent condition and carries good prognosis. If it's malignant, it is stage dependent and it may carry worse prognosis at later stage. Okay, all right. So you can actually differentiate the ovarian tumor based on these few principles. All right. So your questions largely will look something like this. These are typical MEQ questions where they can tell you the age of the patient, 27 years old, 30 or 40. All right, and they suspect that the mass is actually originating from ovary, right? So which clinical features will indicate that the cyst is benign, outline with reasons, the investigations you will undertake on her, and justify your subsequent management, right? So let's try to answer this question using the knowledge that we're going to impart soon, right? This table summarizes basically your 3 groups, all right? So you've got your benign, borderline, and malignant, all right? By just looking at the age group, all right? What was the patient's age just now in the exam question? 27. Alright, so do you think what category is she in? Most likely benign. Alright, so most likely benign. So just looking at the age, you can actually make a deduction that what sort of mass you are dealing with. Borderlines are usually younger women between the age 30 to 50 years old. Alright, so if I'm a very kind examiner, I will give you median age of 40. Alright, so if you hear the word 40 years old, always think about borderline. Alright, okay, so borderline tumors will start arising around 40 years old. Alright, anything you are dealing with postmenopausal, first provisional diagnosis is ovarian malignancy. Okay, then you can think about other causes. Alright, symptom-wise, majority of your benigns are incidental finding on an ultrasound. Alright, they are often asymptomatic. Malignants will start having all these constitutional symptoms. They usually will present with ascites. But remember, ascites is not the only, ovarian malignancy is not the only clinical feature for ascites. You can also have ascites in a benign condition. Alright, okay? So remember that, but often when it comes ascites postmenopausal, you think about ovarian malignancy. Okay? Now the first investigation tool that you must always use is ultrasound. Ultrasound will help you to characterize the masses. Okay? Even if the ovarian mass is incidental finding on a CT or MRI, you go back to your basic, you do a ultrasound. Okay? Alright? A benign mass will always look simple unilocular cyst. Alright? Borderline masses, most of the time, if you are using an IOTA classification for your ultrasound, it will be inconclusive. Right? That will be at least one benign feature and one malignant features. So therefore, it is classified into that 20% of ovarian masses which are inconclusive. Malignants have got these 5 characteristic features: bilateral, multiloculated, at least 4 papillary projection, solid areas, irregular surface, and ascites. Okay, right? So if you're answering for your exam, these are the features of malignancy that you're looking for. Alright? Dopplers, of course, high vascularity in malignant cases. CA125s are almost always elevated in advanced ovarian cancers. They are only 50% elevated in early stage ovarian cancers. Right? If you're using an RMI works for postmenopausal women. Alright? Premenopausal, it is not so effective. Alright? So you categorize them into intermediate risk. Alright? Malignant, usually it will be high RMI. Okay? Now, surgery, you can always offer the minimum surgery for benign. You can even, in fact, do not need to do a surgery for benign cases, alright, for certain conditions. Fertility sparings are always possible with borderline ovarian tumors, right? Because they are usually unilateral masses. Okay. For malignant, of course, you always look for to clear the disease, so you want to do as much as possible a radical staging. Chemotherapies are always required for malignant, not for borderline. Prognosis are very good in benign and borderline cases. Alright, so fertility preservations can be done for benign, yes, borderline, yes, rarely in malignancy. Right, so you can see like stage 1A, you can do a fertility preservation. Okay, now let's look at some of the common benign ovarian masses. So if the age falls into adolescent, right, so you want to think most common conditions are germ cells, right? Germ cells, you can think about dermoid cysts being the most common neoplasm, but always think in your mind whether these are functional cysts, para-ovarian cysts. Endometriomas are less common, but it can happen in older adolescent. If you are dealing with premenopausal women, you think mostly it is functional, right? Depending on the size. If the size is less than 5 centimeter, these are mainly functional. Even 5 to 7 centimeters, you probably want to observe for a few cycles before you make a decision. If at all they are having a triad of chronic pelvic pain, right, infertility, you might want to think about endometrioma or even polycystic ovaries, right? If it's a cystic neoplasm, it is always present on your scans, right? You might want to think about dermoids or serous or mucinous cystadenomas, right? Dermoids usually occurs less than 40 years old. Serous or mucinous cystadenomas, they occur more than 40, right? In postmenopausal, the commonest types of ovarian masses are still benign, alright, not malignant. Okay, they are still benign. The commonest causes will be epithelial type. So the common benign ones will be your serous cystadenomas. If they are simple cysts less than 5 centimeter, most likely this is benign, and you can actually follow them up with ultrasound surveillance and tumor marker. But if they are complex, you need to rule out malignancy. Okay, so your initial assessment for your essays, you must write that you are looking at risk factors, alright? So you're doing a thorough history, looking at risk factors, whether this patient has got a family history of breast, colon, uterine or ovarian cancers, any BRCA gene mutations or possibility of Lynch syndrome. You also can look at protective factors, whether this woman had a multiparity, has she has established breastfeeding, alright, because this would reduce the risk. Using oral combined contraceptive pills also will help to reduce the risk. Okay, if the woman is already in a menopause status, alright, you need to think more of ovarian malignancy. Okay, in the premenopausal group, you are trying to associate things like endometriosis, so look hard for chronic pelvic pain, dyspareunia, alright, painful menses, and infertility. Alright, always make sure you do a careful examination of the abdomen and vagina, and also check your cervical lymph nodes. Now, ultrasound is the best initial imaging modality for ovarian pathology. The best modality would be a transvaginal ultrasound. Okay, alright? If you're not able to do a transvaginal ultrasound due to some contraindication, you then proceed with a transabdominal ultrasound. Okay? Because ultrasounds have got a sensitivity of up to 91% and a specificity of 81% to diagnose ovarian cancer. Okay, alright? If you're using a classification to characterize your ovarian mass, one of the best classifications available now is IOTA. Alright? If you're doing it on CT scan or MRI, you can use the ORACS. Alright? So IOTA are primarily used in premenopausal women, and the features are similar to RMI, right? So any presence of M rule means malignancy rule, you must refer to a gynae oncologist. Right? Now, if on the ultrasound, okay, if the only thing you see is a ascites, it has got 95% positive predictive value for ovarian cancer. Okay, alright, so if the only thing you can see is ascites, do a tumor marker and treat this as malignancy until proven otherwise. Okay, IOTA simple rules works by classifying a mass as benign if at least one of the features is benign but absent of any malignant rules. Okay? Similarly, malignant ovarian masses are defined by presence of at least one malignant rule in the absence of a benign rule. Right? So you can see what are the benign rules and malignant rules. Right? There is also a picture of the iota simple rules. Okay. Now, in the absence of this, where you got a mixture of benign as well as malignant rule, the masses become inconclusive. Right? So if you see benign rules fits a benign ovarian mass very well, and the sensitivity is up to 95%. Alright? 20% of the masses will be classified as usually borderline. Alright? So this is when, if you look at the HPE of the final ovarian masses that has undergone ultrasound and the diagnosis was inconclusive, most of it are borderline or early ovarian cancers. Alright? We also have benign descriptors, so you've got up to 4 benign descriptors, where if you see these features, okay, for example, your unilocular tumor with ground glass appearance, largest diameter being less than 10 centimeter, and in the premenopausal women, this is typical presentation of a endometrioma. Right? Similarly, for ED2, when there is presence of acoustic shadowing, this becomes a benign cystic teratoma. The shadowing is because of the hairball or the fat deposits between the ovarian masses. Okay? ED3 defines a simple cyst or cystadenoma, can be a serous, usually it's a serous cystadenoma, and ED4 is for remaining types of ovarian cysts, benign. Right? For malignant, there's only two descriptors. One is a tumor with ascites, right? At least moderate color Doppler, and the other description doesn't involve a ultrasound. If you have an age more than 50, CA125 more than 100, this is defined as cancer. Alright? Okay. Now, most ovarian masses can be detected on CT or MRI. You will need to do a further assessment with ultrasound to characterize the mass. Okay? Because CT or MRI do not improve the sensitivity or specificity over ultrasound in detecting ovarian cancer. Okay, but CT is helpful for staging, right? So to determine whether there is any regional or distant involvement once you have determined that this mass is malignant, right? MRIs are usually helpful in large cysts, especially in adolescents, where you want to really characterize the mass before you decide what to do with this patient, right? Okay, so a flow chart, if the mass is physiologically normal, right, you can either discharge the patient or repeat the scan at a different time of her menstrual cycle in 6 weeks, alright? If based on iota you have classified this mass as benign, this patient can be followed up conservatively with a follow-up of 3 to 6 months. Right? If you define this mass as being low risk of malignancy, it can be managed in a general gynae unit. Right? If the mass is of intermediate risk or high risk, this should be referred to a specialized gynae onco unit. Alright, so this is similar to your RMI criteria. Alright. Okay, let's look at some of the features. Alright, for example, if you think this is a physiological cyst, most often they come as a result of delayed menses. Alright, and usually they are unilateral, simple, thin wall, unilocular cysts. Okay. You do not need CT or MRI to diagnose this. Most of the time, tumor markers will be normal, prognosis are excellent. The mass usually resolves within 6 to 8 weeks. So you just need to give an appointment to see them back. Alright. Endometrioma always comes with a triad of dysmenorrhea, dyspareunia, subfertility, and chronic pelvic pain. Most often they're unilateral, they can be bilateral in certain cases. Ultrasound shows a low-level internal echoes with ground glass appearance, and MRI shows a high T1 signal and T2 shading. Right? CA125 are falsely elevated in endometrioma. Right? The problem with the prognosis, they are recurrent and may impact your fertility outcome. Right? So you will need to choose which patient you want to do surgery on. Okay, dermoid cysts, they are common in women less than 40 years of age. They are often has got risk of torsion. So your exam question comes with risk of torsion less than 40, you know the answer, alright? They are often bilateral in 10 to 15% of cases, so most of the time they are unilateral, alright? They have got a very unique feature of ultrasound. At all you need a CT, it will be to determine the fat component. CA 19.9 may be mildly elevated. The prognosis is excellent for fertility sparing. Similarly, serous cystadenomas, they are often asymptomatic. They are unilocular with mean size of 5 to 8 centimeter. CA1 to 5 is not elevated. Surgical removal might be required if it's larger. Mucinous are almost always unilateral. Okay, almost always unilateral in 90% of cases. These masses can grow as large as almost 10, 20, 30 centimeters. They usually come with abdominal distension, pressure symptom, leaking, alright? Typical features are multiloculated thin septation and low level of internal echoes, right? So the thing with mucinous cystadenoma, they have got potential to become borderline, right? Fibromas are solid adnexal masses. They are not cystic. They are solid. They often associated with ascites and pleural effusion and unilateral mass. They are almost always benign, right? Okay, so you will see a posterior acoustic shadowing on your ultrasound. Prognosis are usually excellent, right? So this is a summary of the features, okay? So key takeaways would be endometrioma may impact fertility. Dermoid always has got a risk of torsion, so you must remove electively. Mucinous cystadenomas has got chance of being leaking and borderline, so you need to remove surgically. Fibromas are usually diagnosis for differential diagnosis for ovarian malignancy as they got ascites. Alright. Now the approach for ovarian cyst management largely depends on the size. Okay, anything less than 5 are simply observation. Between 5 to 7 are repeating ultrasound. More than 7, you need to refer to the gynecologist. Postmenopausal, usually you will need to do RMI triaging to determine the severity of malignancy. Okay. So indication for surgery in a premenopausal only when the mass is persistent, more than 5 to 7, features of complex or symptomatic. In postmenopausal, the indication would be if you're suspecting ovarian malignancy, your surgical approach should be avoiding cyst rupture. In premenopausal, it is for fertility preservation. Alright? Okay, next let's look at borderline ovarian masses. Okay, these are low malignant potential. They have got 15 to 20% of epithelial ovarian tumors, right? Median age 40 years. They are often diagnosed as stage 1 borderline, fecal borderline. Main histological types are serous and mucinous. They carry good prognosis. The molecular profiling for borderline are unique. They have got BRAF mutation, which is associated with early disease, alright? KRAS mutation has got higher recurrence risk. Alright, they are distinct from ovarian cancer. Okay, surgery is always the cornerstone for any borderline ovarian mass. You do not need routine lymphadenectomy. You do not need chemotherapy usually. Alright. Next will be ovarian cancer. We'll talk about non-epithelial ovarian cancer first. This accounts for 10% of ovarian cancers. They occur in younger women, adolescents. Main types are germ cell and sex cord stroma tumors. Clinical presentations are different. For germ cells, you have got a rapidly enlarging pelvic mass. They often comes with torsion, rupture, and may be associated with precocious puberty, right? For sex-cord stromal tumors, they have got abnormal uterine bleeding or postmenopausal bleeding. Often there is endometrial hyperplasia, so look hard for a thickened endometrial lining. And patients may present with realization. This is a cytolic bleeding. Investigations are also unique. Of course, you don't run away from TBS. Tumor markers are quite unique for each of the subtypes, right? Now, for early stage germ cell tumors, you can do a fertility preservation where you can do a USO, unilateral salpingo-oophorectomy, alright? Surgical staging means you need to do everything. You need to do your collecting peritoneal fluid for cytology, infracolic omentectomy, pelvic lymphadenectomy. Alright, that is surgical staging. But you only do a unilateral salpingo-oophorectomy. You preserve the uterus and the contralateral ovary. Alright? Advanced stages, you can also try to do fertility sparing as much as possible because this ovarian cancer carries a very good prognosis even in the advanced stage, even if it's stage 4. Right? So, and they are highly chemosensitive, so you can actually give an adjuvant chemotherapy, but the regimen will be BEP regimen, and they have got a cure rate of more than 90% even at stage 4. Okay, right? Sex-cord stromal tumors, most often the mainstay of treatment is surgery. We often do fertility preservation in young women and aggressive debulking in postmenopausal women. Their chemotherapy is also BEP or paclitaxel based. Granulosa cell tumors, you can actually give some hormonal therapy. Okay, last few slides. We will now talk on epithelial ovarian cancer. This accounts for 90% of ovarian cancers. Peak age is 60 to 70%. You will take note of the risk factors. They have got familial tendency in 20% of cases. Majority of them are spontaneous mutation. Right? Main histological types are high-grade, serous ovarian cancers. If you've got the endometrial and clear cell, look for association with endometriosis in the past. Right? Most important is low-grade serous ovarian cancers can actually evolve from the borderline ovarian tumor in the past. So history taking is important. Mucinous ovarian cancers can also have any GI as the primary. So look out for any other origins. Nowadays, it is a standard practice to do genetic testing on your tumor tissues, so make sure patients are sent for germline and somatic BRCA mutation as well as HRD testing, which is often detected in 50% of the ovarian cancer tissues. Okay, clinical presentation is quite vague, but you can look for persistent bloating, eating difficulty, abdominal pain, and frequent urination or altered bowel habits for surveillance. Alright. Investigations, again, you don't run away from TBS. CA125s are elevated in most cases. You will need to do triaging with RMI, mainly for postmenopausal group. Now we have got something called ROMA, which includes HE4, right, on top of CA125. CT abdomen for regional and distant involvement, right? You must obtain tissue diagnosis. So this is important. In your exam question, if you think you're dealing with ovarian malignancy, you say you must do a primary debulking surgery to get histological confirmation. Or if you think you want to give a new adjuvant chemotherapy first, you must do an image-guided biopsy. Alright? CA125, non-specific. If they're elevated, very good. Alright? If the levels has got more than 250, please discuss with gynae oncologists. Alright? RMI, more than 200, high risk for urgent referral to gynae oncology. Alright? HE4, in combination, you can actually use it for Roma, right? But it is similar sensitive but less frequently elevated in benign gynae conditions, including endometriosis. So this is a good alternative can be falsely elevated in renal impairment. Alright? So tumor markers, you can do a ratio of CA125 and CEA. Alright? If your CA125 CEA ratio is less than 25, alright, you will need to send for colonoscopies or endoscopies. Alright? Other biochemical markers will come into place as the tumor subtypes differentiates. Right? Okay, these 5 images are important for you to determine ovarian malignancy on an ultrasound. Alright? Okay, so this is important. Now, once you've done the IOTA classification on ultrasound, you can then actually use a IOTA NX calculator to determine whether this mass is going to be borderline for you to give an option of fertility sparing, or in early stage cancers, you can actually refer to the gynecologist. Advanced stages, you can offer primary surgery or interval debulking, and if you suspect secondary metastasis, referral to other fertility for primary tumor origin investigation. Okay? So again, management of epithelial ovarian cancers early stage. Stage 1A, you can offer fertility sparing, but you need to do the full staging workout. Alright? Adjuvant platinum-based chemotherapies are for high-risk cases. Okay? Advanced stages, we've got the 2 options that I've told you. Chemos are almost always carboplatin, paclitaxel, 6 cycles. Nowadays, we've got PARP inhibitors and bevacizumab. So you can use PARP inhibitors as a maintenance therapy in BRCA-mutated platinum-sensitive recurrent ovarian cancers, or as a first-line maintenance in BRCA-mutated advanced ovarian cancers. And this has shown to prolong progression-free survival at least up to 5 months. Okay, right? I think I'm done. So this is the table to summarize your 3 classifications. Right? Thank you very much. This was the exam question. Maybe you all can have a look later at the answer. All right.
Thank you, Prof. Nimala, for the comprehensive and insightful presentation. We will now proceed to our next session that will be presented virtually by Prof. Dr. Muhammad Nasir Shafi'i, Senior Consultant Gynecologist, Deputy Dean, Faculty of Medicine, UKM.
Siapa yang jaga acute station apa dah tukar? Sub ke apa ke yang cari sendiri? Kalau ni then you minta tukar sub-sub, cari sub-sub. I tukar yang acute je, yang acute station. Siapa sekarang dekat Villa? Masalah sebab ada Istidah dengan Dr. Diana tu, diorang rajin ajar. So kita orang seorang-seorang attach so diorang ajar lah. Ilani memang tak pernah take patient kat sini.
Prof, can you hear us? Kejap, right? We are changing the speaker. Bas. Prof, boleh share screen ke Prof?
You see that?
Yes, Prof. You can see. You may proceed, Prof.
Nampak?
Yes, Prof. You may proceed. Yes, Prof. Nasir, we can hear you clearly. You may proceed. Thank you.
Alright, okay. My voice is loud and clear.
Yes.
Is my voice is loud and clear? Okay.
Yes, thank you, Prof.
Alright, okay. Thank you very much. Right, okay. Assalamualaikum dan selamat pagi. I'm so sorry. I need to be away from your locality. Basically, I'm at home today. Got some work personal. I couldn't see the crowd, but I'm sure it is a good turn out from candidates for masters. Okay, right. Thank you juga kepada the organizer for inviting me to give this topic, which is actually quite close to my heart. This is one of my interests in the endometrial cancer. So I'm given 30 minutes, but there will be two parts of my presentation. So for the first one, probably I'll take about 20 minutes, 15-20 minutes. So we're going to look at the evidence that we have so far with regards to the treatment of the endometrial cancer and also the risk stratifications that we're using currently, right? And the second part will be a bit more on clinical, especially to target for your preparation for the exam, this coming exam basically. Right, so let's move on. So basically the topic is on the risk stratification and the treatment algorithm. So what we can see now, people worldwide is moving from the traditional ways of risk stratification by using the histopathological immunostaging to the more precise molecular stratifications, that we're going to talk about it later. Okay, so you know endometrial cancer is one of the famous cancer, if I could say that, in gynecology. And in fact, if you see a Malaysian data that indicates now endometrial cancer is the top among women in Malaysia, that surpassed cervical as well as the ovarian cancer. No? Before this, we can see the cervical cancer is the topmost cancer in Malaysia, right? And well, although we say that endometrial cancer happening in more developed countries, in US, in UK, in Europe, yeah, but it's not. This is not the best indicator to say that Malaysia also now in developed country, yeah, right? And the lifetime risk of women to develop this cancer is about 3% in the world, right? But if you look at into the general geographical, you can see the black women, especially in US. They have higher mortality rate as compared to the white women. Many factors, likely is because of the non-endometrioid subtypes, and it's also probably happening ataupun present rather quite late before they've been diagnosed as the endometrial cancer. And this is what you can see the shift that we have now. Previously using the microscope just to look at the morphology of the cancer of the endometrium, and what we normally see is basically to look at this, look at the grade, we look at 1, grade 2, grade 3, looking at the subtypes of the endometrial cancer, whether you have the endometrioid or other non-endometrioid, for example, serous, papillary, clear cell, yeah? And also it also depends on the myometrial invasion, just looking at the DNA broidy sometimes, yeah? So that's actually basically looking at the microscope only, right? But now with the new TCGA, that's actually looking at the genomic characterizations of the tumor cells, or the tumor biology or tumor DNA, to look at a better behavior of the cancer itself. Yeah? And with this new purpose, new proposed staging by FIGO starting from 2023, and people worldwide is trying to advocate this and trying to incorporate this certification in the clinical use. Although not all centers are able to do that because of the cost, and as well, and even the majority of the government hospital in KKM, even UKM, we are not fully utilize these classifications because again it's because of the cost, right? Right, so if you're looking into at this PROMIS algorithm, this is actually the molecular certifications. There are 3 things that we're looking at, yeah? If you can see, basically we're looking at the MMR status, looking at the pole sequencing, and also looking at the P53 by using immunohistochemistry. From that test or examinations, we're going to look at or classify cancers, endometrial cancers, into 4 categories. Whether they are pole mutated, yeah, whether they are having MMRD or MSI, whether they are having copy number low or we call non-significant, or we call it as the P53 abnormality, or in other words we call it as copy number high. So every category has different characteristic of the cancer tumor behavior. If patient has pole mutation, pole basically for your information is basically an enzyme that basically surveying any abnormalities in terms of the proliferations, or as well as the tumor as a cell differentiation, right? So let's say kalau the pole ni, enzyme ni, di jalan tengok dekat the DNA sequencing and it found, oh, this is abnormal. This enzyme is basically to work on that, alright? If having pole mutation, in the other words, this enzyme cannot identify area of abnormality, so the cell will keep growing, becoming a cancer, a tumor. And when they have this high intensity of divisions, they will develop or form as neoantigen. Maksudnya benda asing lah ya, ataupun warga asing or whatever, right? So with this neoantigen, our immune system can detect this abnormality or the cancer, hence our immune response will come and kill that cells. So that's the reason why when you have pole mutation, you have better or good prognosis because of this interaction. Okay. The second category we call as MMRD, ataupun kita panggil mismatch repair deficiency, ataupun adalah MSI. So MMRD is actually a genes, and MSI is a protein. So maksudnya MSI terjadi daripada MMRD. So we want you nak sebut MMRD ke MSI ke, terpulang kepada you. It does not matter in general, right? So basically what happened, ini juga adalah surveillance. So it's like a system, macam supervisor dekat line kilang macam tu, right? So this MMRT ni, we just walk around at the line in the kilang and find, oh, this is abnormal or this one abnormal. So if ada MMR deficiency, bermaksud that DNA cannot be repaired. So kalau tak repaired akan ada more abnormality, right? So it become cancer. For MMRD, the lain sikit pada pole. Pole tadi dia terlalu high density sampai tak dapat buat apa-apa. MMRT ni dia slow density sikit in term of recognizing it, alright? So it continue to have this abnormality when the patient is having deficient, alright? With non-significant NSMP ni, low copy number low ni, basically dia punya pole pun tak ada, not mutated. Dia punya MMRD proficient tu masih normal, deficient tu masih tak normal. Lepas tu dia punya P abnormality pun is normal, right? So it categorized into this non-specific, okay? And usually it is associated with estrogen or progesterone receptors positivity, okay? And the last one is P53 abnormality, or in that word, this is the jahat one, the most jahat one, whereby if the P abnormality is present, it indicates the patient has poor prognosis. Okay, right. So I'm going to also touch on this fertility sparing management, because I'm sure now you could see many people diagnosed with endometrial cancer at early age. I got at least 10 patients that age less than 30, 20 plus, and they have this cancer. So in many consensus and guidelines, which I summarized into UK as well as US, not UK, actually the European guidelines, as well as UK guidelines, to look at how they manage this condition, right? So basically, generally standard, the fertility preservation can only be done grade 1, stage 1A, means that no myometrial invasions, and also endometrial subtypes. So you must remember this, Don't ever suggest the patient to do fertility preservation when they are on this stage 2 and above, right? Because I could still receive some referral. They say that want to do fertility preservation, right? We can do everything that we want to, but if we come into the guidelines, when the lawyer want to sue you later, so they must refer to the guidelines, certain guidelines, and you'll be tried. You can discuss with the patient entirely, that's their decisions, but the best to provide the evidence base. And usually, if the patient has the desire to have this fertility preservation, what we could do, basically, we give them progesterone-based treatment, okay? Minorina or levonorgestrel IUD has been proven to be good with as high as 95% regression rates of the endometrial cancer stage 1, alright? In certain conditions, you can also add on with the oral progestin. Either you want to give magnestrol acetate, but usually in our center we give MPA with a dosage of 400 to 600 milligram per day, right? Don't give 10, 20 milligram TDS. I could see sometimes some patients has been on that treatment for this treatment of this hyperplasia and also this cancer. For on this treatment for the past 3 to 6 months already. That's not enough, And even if you want to put on with the metformin or any other forms of anti-metabolites or anti-insulin sensitivity treatment, that is okay. And even some study shows that is a better regression rates. Okay, so as it also can change the metabolic of the condition. We can do this as maximum. If you're looking into the UK European guideline, maximum of 6 months, with the intensity follow-up every 3 to 6 months to repeat the biopsy or to do the cystoscopy or to take the biopsy. But if you're looking into the US guideline, NCCN, the maximum that you can go until up to 1 year. Alright, after 6 months you assess, kalau masih ada, it's not regressed yet, you still have to do you can do the CT scan to reassess, or even to do MRI or PET scan to reassess before you allow to go in another 6 month treatment using medical treatment. Alright. And if you look into other guidelines, it says that either you do PPAL sampling alone, or you have to do PPAL or you want to do the hysteroscopy and curettage, is actually having similar efficacy following to ESMO's guidelines. However, in highly suspected condition or even before they diagnose a cancer, if you highly suspect, you do PPAP negative, then you still have to do the hysteroscopy and curettage, so that you don't miss 10% of the condition which could have negative on your PPAP sampling, right? Okay, comes and now we look at into the staging operations in general. Right, the gold standard treatment still for all endometrial cancer generally is total hysterectomy and BSO. Okay, but in certain conditions, for example, they are still young, they still want to keep the ovary, it is possible. However, you got to make sure a few conditions, like to those who's having non-endometrial, mean that serous, papillary, yang jahat-jahat macam tu, and it's not recommended to keep the ovary. That's number one. Yeah. And the other thing is, people asking now, because we have the minimally invasive surgery, robot, laparoscopy, which one would be better? Generally, as principle, yeah, minimal invasive surgery is strongly preferred to reduce the morbidity that related to the operations, like mainly wound breakdown or wound infection, hospital stay, dan sebagainya. However, in the case that you suspect the extension of the disease outside the uterus, or even the likelihood of having other stromal invasion, for example, then in many guidelines suggest for you not to do the laparoscopic minimally invasive surgery, right? As because the risk of rupture of the tumor. What about the lymph nodes? Yeah, lymph node. We are moving now toward the sentinel lymph node mapping, whereby by putting this ICG, it could identify the first nodes that the tumor invaded and remove that area. By doing this, of course, you remove all possible risks and complications of lymphadenectomy, like having injury to the nerve, bleeding, longer operation time, or having the lymphoedema that very much related to the lymphadenectomy, right? And now, I think worldwide we're looking at the pathologic ultra staging, right? Usually people just looking at the cells in the nodes to see whether positive or negative the metastasis, but with the pathologic ultra staging, people looking at the micro metastasis, very small, less than 2 millimeter, by looking at how many cells that is positive inside the tumor cell itself. Okay, all right. So now we recall everything that we learned just now. Just now we have some touch about the molecular, then we have about the clinical surgeries and blah blah. Now we are looking at how we are going to integrate these two. Okay, if the patients who has stage 1 to 2, yeah, and having pole mutation, abnormality pole mutation, we downgrade to the low risk. This is the beauty of having this classification. Yeah, so with the low risk, so basically likely patient do not need to go for any further treatment or adjuvant treatment, although there are having a stage 1B, for example, even stage 2. Okay, what about for those who have P53 abnormality, right? Kalau patient even at early stage but they have P53 abnormality, suddenly their risk is upgraded to the high risk, whereby we need to do further adjuvant treatment for them. Yeah, but just in the middle ground, for those who have the NMRD ataupun non-specific tumor, yeah. So what we need to do is basically go back to the clinical pathological staging, that looking at the myometric invasion, LPSI, grading, dan sebagainya, right? Even now, people looking at the presence of estrogen and progesterone and estrogen receptors positivity in the tumor cell, which can also determine whether they can give any hormonal treatment or therapy for this reason. Okay, mentioned just now, low risk, yeah, you go for observation. However, intermediate risk, for example, having stage 1B with presence of MMRT ataupun non-specific, and then you go for a brachytherapy. Yeah. However, if the patient who have P53 abnormality, mainly what they need to do, they need to go for surgery plus systemic chemo and also external beam radiotherapy, right? And to date, we have this PROTECT3 trial that demonstrate the overall survival and the free survival advantage among people who have a combination chemo and radiotherapy rather than radiotherapy or chemotherapy alone. Yeah. Right. So now let's see the differences between these European as well as American, the gross differences in terms of the risk stratification. You can see for the European, we have comprehensively integrate molecule into the 5 specific risks. You know that low risk ada kita ada low risk, kita ada intermediate risk, and then we have intermediate high risk, then kita ada high risk and advanced risk, right? Ada 5 lah, ya. Alright. So and with this we could see whether the patients need to go for comprehensive infracolic lumpectomy for high risk staging, whereby this certification not only after you do hysterectomy, no, even after the biopsy result, you can get that classification to tailor your surgery or the needs of your surgery. Same thing with lymphadenectomy. If there is presence of high risk, you tend to do more radical, systematic, yeah. And sometimes in certain guidelines, major guidelines recommend to go for the bariatric lymphadenectomy as well. As for the NCCN, American guidelines, also encourage to go for the molecular testing, especially MMR. Kalau tak ada buat benda lain pun, dia kata buat MMR pun cukup lah, ya. Because that can basically dictates what adjuvant treatment pathways needed for the patients, yeah. With these American guidelines, it recommends less invasive omental biopsy rather than you do the thorough omentectomy infracolic, for example. So you just take some big chunk of the omentum, that will be enough. So these differences in the guideline is basically to guide us. Whatever we do in clinical practice must be individually tailored to the patient to see which one is more applicable, right? So I'm just go through with the guidelines to make sure that you're aware about the present. MMR deficient, basically, as I said just now, it's just like in the middle, intermediate risk. And for your information, 20% of patients who have Lynch syndrome is because of this MMR deficiency, right? So if the patient who has this kind of condition, MMR deficient, one of the beauty things about it, there is a presence of immunotherapy that would help better in terms of a patient who has recurrence or even advanced disease at the first time when they diagnose, right? And immunotherapy has been proven in RUBY and also GY018 trial, yeah, that give a better progression-free survival for a patient that use this dostarlimab, yeah, as compared to those who just receive a standard chemotherapy carboplatin paclitaxel alone. Okay, so what is the next people looking at? Nabil, nampak orang muka. Okay, finishing. Okay, alright, okay. So for the next generation that people looking at now, looking at the targeting HER2, like what we are doing in the breast cancer, yeah, and so looking at the presence of the hormone positivity, whereby we can use letrozole, yeah, and also looking at the targeting DNA damage, whereby olaparib or PARP inhibitors like ovarian cancer can be used as well in the endometrial cancer. Now, basically, we got two ways, yeah, between the risk and the benefit of doing a surveillance. Yeah. Nowadays, even in my clinic, sometimes some registrar asking, nak buat board smear tak? How frequent you want to do board smear? Nak buat CA125 ke tak? That has been lingering in our mind to do or not to do it. Yeah. But based from these guidelines, international guidelines, well, it indicates that doing the CT scan routinely, CA125 routinely, pap smear routinely does not basically improve the patient's prognosis. Okay, but we can reserve this for certain condition. For example, someone who have early during diagnosis has increased CA125, and then you have to monitor CA125, of course. Yeah, someone who probably suspected to have any kind of symptoms which you can determine, then you have to do the CT scan. Yeah, and pap smear looking at cross-medical guideline is not indicated unless it is found something abnormality, or even before this patient has CIN lesion, for example, in the cervix, then you have to monitor at the same time, then should be alright to do the board smear, right? And the follow-up, it should be generally 3 to 5 years, okay? And many recommendations that you need to initial follow-up every 3 to 4 months, alright? And then continually until yearly, until they achieve into 5 years before you can say that you're alright. In fact, in high risk, you still have to continue even after 5 years. Okay, this is generally the summary with regards to the precision care of the patient that we use the staging. Yeah, so people looking at the atlas that we have, promise classifications, and this has been generally proven to be beneficial in tailoring the best treatment to our patient. If we're able to do that, we should adopt this condition. Yeah, although in many countries and centers, this is not widely practiced because of, I said just now, because of the cost mainly, right? Why it is very important as well? Because we could determine whether you want to escalate or de-escalate the treatment in terms of surgical or even the neoadjuvant treatment, if we are going to give later. And also we could target certain pathways, certain areas of carcinogenesis, for example, like having HER2 or even giving them hormone therapy that could potentially improve the prognosis of our patient. Alright, okay, so do you have any questions so far before I just want to sum up with the next slide? Ada tak soalan yang tanya? Silakan, kalau ada soalan duduk boleh. Ada tak soalan? Tak ada?
Ada Prof.
Okay, alright. So I will go for it. Wait, where is my thing? Wait. Okay. Sorry, I'm not familiar with this laptop. Okay, right. Okay, now let's go to more exam-oriented things. Alright, so let me put this away. Okay, alright. Okay, so generally in the exam, now we got to use whatever we learned just now, right? Exam must be comprehensive, concise, and also must be sound in terms of the knowledge as well as in terms of the practice. Okay. Someone who come to you with the with the ovarian, with the endometrial cancer, right? So first, you need to do the pre-operative workup, right? So katakanlah someone the question is critically appraised management of the endometrial cancer in 49 years old, something like that, right? So you pun jawab lah, yeah. So first, you basically to look at the framework. You must have pre-operatively what you're going to do. You need to do molecular classification or not, yes or no, what primary treatment, adjuvant treatment, recurrent nak buat apa, follow up macam mana, so that you have the whole set of it, alright. So when patient comes to you, 90% of the abnormal uterine bleeding is the features of the endometrial cancer. So endometrial sampling is a must, right? So what you do, you basically can do office biopsy like the pill that you're doing. You want to do fractional DNC, for example, yeah, or even you can do hysteroscopy. In ESMO's guideline, they said you can do anything that you want to do. Nak buat office ke, nak buat pipel ke, nak buat apa, doesn't matter, right? In CCN, dia kata you buat dulu pipel. Kalau pipel tu negatif, but you have high suspicion, baru you buat hysteroscopy and DNC, whatever you want to do. So you must say that it is a must to do this, alright? Okay, so when you confirm it's the cancer, the next what you need to do is you got to assess as well the imaging, like doing transvaginal ultrasound, has very good sensitivity specificity to look at the myometric invasion, yeah, as well to look at the presence of other concurrent diseases in the uterus, yeah. And then pelvic MRI has been given the top priority compared to the CT scan of the pelvis, thorax, abdomen, yeah. However, if you have some limitation with the MRI, you can just go for the pelvic TAP alone, right? And this CT scan will give you a better understanding with regards to the node metastasis before you put beside the surgery. Right. Another thing is a PET scan that getting more popularity now, but I'm sure with the cost, very limited availability that that we can offer. But if you have to do it as a surveillance later, that would be advocate as well. Alright, now you get the results. From the result of the biopsy alone, you could determine, pathologist could determine whether they got this bone mutation, ada MSI, copy number low, high dan sebagainya, because that would tailor the surgery that you're going to do, and in fact subsequent treatment later on. Yeah, right. In terms of the primary treatment, what you can do is a standard treatment that we normally do for our patient with the endometrial cancer is total hysterectomy. This total hysterectomy, you can debate whether you want to do laparoscopic, robotic minimally, you want to do abdominal, benefit, risk, challenge dan sebagainya, right? In your X-ray, for example, right? In terms of the bilateral saphengolectomy, whether need to do it or not, it depends on, again, saya kata tadi, kalau high risk, maksudnya kalau you suspect, kalau post-menopause, do question lah, I'm talking about the perimenopause, yeah, or premenopause, yeah, whether you want to keep or not to keep, depending whether the grade is okay, whether they got the high risk subtypes okay ke tak, kalau it's endometrioid, everything okay, early stage you can keep it, kalau tak, then you have to remove that, yeah, right? And then come to the minimally invasive approach as well. In terms of nodes, you basically would see whether you want to do sentinel nodes. You can debate saying that sentinel nodes reduce mobility dan sebagainya, shorter operation, if you got the equipment, you can go for that. Otherwise, in a high risk, for example, or even suspected nodes metastasis sebagainya, you can just do systemic lymphadenectomy, or even you can also offer ultra staging, that can be being advocate to reduce risk of missed positive lymph nodes in the operation, right? Okay, and then you can also tell if the patient, ni kalau patient tu dia letak, kalau AC umur 50, janganlah cakap fertility sparing option, but you have to tailor to the patient, to the question. So we're talking about someone 45, for example, you don't know whether she's in like 45 and below, whether she need to go for pregnancy, whether she got any parity dan sebagainya. So you can say that progesterone or progesterone treatment is the mainstay for the fertility sparing, but you have to tell exactly what you will need to do while you're monitoring them, what will happen, how long you're going to give them chance to get a pregnancy following the negative results or the negative histology of cancer. What about adjuvant treatment? So we have radiation ataupun systemic radiotherapy. So radiation, either you give vaginal brachytherapy to reduce local recurrence or VOC recurrence, and also external beam if especially the nodes positive, right? So sometimes in certain centers, not here, they use the intensity modified radiotherapy so that they can basically give higher intensity of the area where the lesion were positive during this surgical staging, right? Or the systemic treatment, you can give the chemotherapy, carboplatin paclitaxel, immunotherapy, getting more popularized now, and has shown to have a better survival and also PFS, progression-free survival of patients when they receive this immunotherapy, or even hormone therapy in selected cases, especially in those who have ER, PR positive patients. What about for those who have recurrent advanced disease? Now people go for targeted therapy as well. I didn't want to give PARP, all these HERS to target and sebagainya, which I must say that it is relatively quite premature for us, but you can just mention targeted therapy. You don't have to memorize all this kind of treatment because not widely available in our centers or even in Malaysia. Yeah, cytoreductive surgery, yeah. Dulu last time it's just think about the hysterectomy intention to cure the disease, right? But in this cytoreductive surgery, we do for patients who have metro bleeding, metromenorrhagia dan sebagainya. So even though it's advanced disease, we still proceed with the hysterectomy to reduce the bulk of the lesion of the tumor before you give them systemic treatment, alright? So still applicable to do cytoreductive surgery in endometrial cancer, or even think about the palliative care if the patient's old, not able to go for any kind of treatment dan sebagainya. So just kasih TRCE lah, yeah, and the loving and care, right? And what about the follow-up? So the most important is to do examination, clinical examination, vaginal examinations, or even pelvic scan or transvaginal scan, that has been shown to be superior as compared to CA125, compared to the smear test or what smears and sebagainya, right? So for those who have increased CA125 initially, you need to monitor them, otherwise do not need to use CA125. And also it's also based on the symptoms, whether you need to do a CT scan, MRI, PET scan dan sebagainya. And dose imaging is not pukul rata for all patients, in selected cases saja. And of course, we need to make sure the good lifestyle, nutrition counselling, make sure the diabetic well controlled, for example, the obesity, bring down the weight, sometimes give metformin and sebagainya. It could help as well at the same time. Okay, I think that's all. Any questions? Ada soalan? Silakan.
Yes, Prof. We do have one question.
Silakan.
Prof, boleh tengok kat skrin ke?
Alamak, tak nampak pula kejap kecil sangat. Bawa sikit. Mana? You bacalah. Salam, in our local practice, any proven HPE of endocancer, in which case we order for testing. Maksudnya kalau katakan biopsi, can you highlight the things? Maksudnya apa? Proven HPE endometrial, in which case we will refer for molecular testing. Okay, alright. So I think if I'm not mistaken, what you mean is, adakah semua you perlu buat molecular testing ke ataupun in selected cases ke dan sebagainya, alright? Generally, standard you do all, okay? But I'm sure in our centers, in localities, we have difficulties, kan? Okay, so basically, you can opt to do initial one is the MRD, mismatch repair. Okay, so in what cases? Almost all lah, sebab MRD tu is much cheaper that you can still do using IC. Kalau POL tu memang you kena buat sequencing. Sequencing mahal, macam you buat aneuploidy test lah, macam you buat NIPT tu kan, kan mahal. So yang ini POL tu macam tu lah juga, ada punya proses dia nak buat tu, dia guna sensor dan sebagainya, segala tu yang single cell sequencing dan sebagainya. So that cost more money lah, about 2,000 macam tu juga, 2-3,000. Okay, ada question?
Okay, thank you, Prof.
Habis?
Yes.
So they don't want to ask me question. I will ask them question when I do wrong next week. Okay? Baik. Bye.
Thank you, Prof.
Alright, enjoy the rest. Goodbye, and go.